Welcome back to the deep dive. Today, our mission, well, it's perhaps one of the most high stakes we've tackled yet. We are diving deep into coagulation modifier drugs. Now, these medications sit squarely on that list of high alert drugs you hear about in clinical settings. And it's not just because they're complex, it's because the margin between helping a patient and causing, a fatal bleed is incredibly thin. Essentially, we're looking at drugs that manipulate the body's ability to clot blood. They have sort of four main goals. They either prevent new clots from forming, they dissolve clots that are already there, or sometimes they actually promote clot formation.
Yeah, and to really get started, we have to understand the core danger we're actually fighting here. We're talking about thromboembolic events. The blockages that lead to things like heart attacks, strokes, or those really dangerous clots in the lungs or legs, DVTs and PEs. The clot itself, that's a thrombus. And if a piece breaks off and travels, well, that's an embolus, and it can be deadly. So our whole discussion today really revolves around managing this delicate balance, stopping the bad clots without causing uncontrollable bleeding.
And I think the most important insight we can give you right at the top, something that will frame everything else we discuss, is this. The specific way a drug stops clotting its mechanism directly determines how carefully we have to monitor it. We can see this big shift, right? From older drugs that hit multiple clotting factors and need tons of lab work to newer ones targeting just one factor, offering much more predictability.
That's exactly right. Okay, so let's unpack the why, the actual biology these drugs are messing with. It's this incredibly complex process called the coagulation cascade. You can think of it like a series of dominoes, highly amplified. There are intrinsic and extrinsic pathways, and one clotting factor triggers the next and the next, ultimately leading to the formation of this strong mesh-like protein called fibrin.
Fibrin, that's the key structural part of the stable clot.
Precisely, it's the framework.
But thankfully, the body has a built-in check, right? A way to stop us from just, clotting solid. The fibrinolytic system.
Exactly. This system's whole job is lysis breaking down that clot once it's done its job, or if it's forming inappropriately. It works by converting a protein circulating in the blood, plasminogen, into its active form, plasmin.
Plasmin.
Yeah.
The clot buster.
You got it. Think of plasmin as like the Pac-Man of the circulatory system. It chews up that fibrin mesh, breaking down the thrombus. Understanding this balanced clot formation versus clot breakdown is really fundamental to grasping how these next drug classes work.
Okay, let's start with the biggest group then, the anticoagulants. And let's stress that distinction again. These drugs prevent a new clot or stop an existing one from getting bigger. They absolutely cannot dissolve a clot that's already formed.
Correct. A critical point.
We'll begin with the sort of foundational agents.
Yep.
Unfractionated heparin and the low molecular weight heparins, or LMWHs, like enoxaparin, Levinox.
Okay, so heparin's mechanism is pretty interesting because it's actually an indirect inhibitor. It works by grabbing onto a natural anticoagulant we already have called antithrombin III. This heparin antithrombin III complex then becomes supercharged at turning off several key activated clotting factors, namely factor 2, which is thrombin factor X, and factor IX.
Okay, so it hits multiple spots in the cascade.
Right. Now, LMWHs, they're smaller molecules derived from heparin. They're engineered to be much more specific. They primarily go after just activated factors I.
So that's the key difference. But if they're both technically heparins, why the big difference in monitoring? Unfractionated heparin, especially that continuous IV drip used therapeutically, needs constant APTT checks, sometimes every 6 hours. But LMWHs, like enoxaparin, often don't need routine monitoring. Why is that?
It goes right back to that mechanism. Because unfractionated heparin hits 3 different factors, its effect can be, pretty unpredictable from person to person. We need that APTT test to make sure the dose is just right enough to work, but not so much that the patient starts bleeding.
Okay.
But LMWHs, by focusing mainly on factor Zacchus, give a much more predictable response based on the patient's weight. So we can usually give a standard dose subcutaneously without needing all those frequent lab draws.
Makes sense. But we can't talk about heparin without immediately bringing up its biggest, scariest risk. Heparin-induced thrombocytopenia, HIT. This is where the drug meant to help becomes, the enemy.
It's a really serious complication, specifically type 2 HIT. It's rare, but it's an immune reaction where the body attacks platelets that have heparin bound to them. You see this sudden, sharp drop in the platelet count. And the truly dangerous, paradoxical part is that this whole process actually makes the patient more likely to form life-threatening clots.
So if you even suspect HIT,
you stop the heparin immediately, no hesitation, and switch to a totally different type of anticoagulant.
right. And since bleeding is always the main concern with any anticoagulant, What's the emergency stop button for heparin if someone's hemorrhaging?
That would be protamine sulfate. It's the specific antidote for both unfractionated heparin and LMWHs. And it works fast, really fast. You see effects within about 5 minutes. The general rule is 1 milligram of protamine neutralizes about 100 units of heparin.
Good to know. Okay, let's shift to the other classic anticoagulant, warfarin, brand name Coumadin. Totally different mechanism, different timeline too.
Yeah, warfarin is the slow-acting one. It doesn't affect the clotting factors already floating around in the blood. Instead, it interferes with vitamin K. The liver needs vitamin K to actually make several key clotting factors, specifically factors 2, 7, NiX, and X. So warfarin blocks that synthesis. But because the body has stores of these factors, it takes a while, usually 36 to 42 hours, before warfarin really starts to show its full anticoagulant effect.
And because of that delay and how differently people process it, warfarin needs that careful monitoring with the PT-INR test, prothrombin time, and international normalized ratio. We're usually aiming for an INR somewhere between 2.0 and 3.5, depending on why the patient is taking it.
Exactly. That monitoring is absolutely critical.
Now, this brings up a huge point for patient teaching, the vitamin K issue. Does a patient on warfarin need to completely cut out leafy green vegetables like kale or spinach?
No, absolutely not. And that's a really common misconception that causes problems. They don't need to avoid vitamin K-rich foods, but they absolutely must be consistent with their intake.
Consistent.
Meaning, if they usually eat a small salad with spinach 3 times a week, they should keep doing that. Someone who eats almost no greens and then suddenly has a giant kale smoothie once a month, their INR is going to swing wildly. It's all about maintaining a steady level. Consistency is the magic word for warfarin and diet.
Okay, that makes sense. Consistency. But what if that consistent patient has a bad fall, hits their head, and starts bleeding? How do we reverse warfarin quickly?
The antidote is vitamin K1, also called phytonadione. We can give it orally or IV. But here's a really important clinical pearl. If you give high doses of vitamin K intravenously to reverse warfarin quickly, it works, but it can also make the paper resistant to warfarin for up to a week.
Wow, resistant for 7 days.
Yeah, it means you might not be able to get their INR back up into the therapeutic range with warfarin during that time, which could be risky depending on why they need anticoagulation. So it's a trade-off in an emergency.
Okay, that's a huge consideration. This really brings us to the newer era of anticoagulation, doesn't it? The direct oral anticoagulants, the DOACs, these really seem to embody that shift towards specific targeting we mentioned earlier.
They absolutely do. We have 2 main types here. There's dabigatran, which its brand name is Pradaxa. It's a direct inhibitor of thrombin factor 2A. And then there are the really popular factor ZA inhibitors like rivaroxaban, that's Xarelto, and apixaban, which is Eliquis.
And the big advantage advertised for these is?
Because they target just one specific factor so precisely, their effect is much more predictable. So generally, they don't require that routine blood test monitoring like warfarin or therapeutic heparin.
That's a huge convenience factor for patients.
Definitely. But they aren't without serious warnings. They all carry black box warnings. One is about the risk of spinal or epidural hematomas if the patient has spinal anesthesia or lumbar puncture. That can cause paralysis.
Oof.
And the other big one, which ties into our final thought later, is the danger of stopping them suddenly. Abruptly discontinuing a DOAC, especially the factor ZA inhibitors, can cause a rebound increase in clotting risk, potentially leading to a stroke or other major thrombotic event.
So stopping needs to be managed carefully too. What about reversal? For a long time, that was the big drawback, no specific antidotes. Has that changed?
Yes, thankfully. We now have specific reversal agents for emergencies. For dabigatran, the antidote is idarucizumab, brand name Praxbind. And for the factor ZA inhibitors, Xarelto and Eliquis, we have Andexa, which is a recombinant factor ZA protein.
So if someone on Eliquis comes into the ER with major trauma or needs emergency surgery,
we now have a way to quickly shut off that anticoagulant effect. It's a major safety advancement.
okay, huge shift. Now let's pivot again. We've talked about the cascade. Let's move upstream to the very first responders when a blood vessel gets injured. The platelets. We're talking antiplatelet drugs now.
Right. And this is another key area where clinical decisions are made. Generally speaking, anticoagulants are the go-to for venous clots, think DVT, PE, where the clot is mostly that fibrin mesh. Antiplatelets, on the other hand, are more often used for arterial thrombosis, like preventing heart attacks or strokes where the clot starts with platelets sticking together.
Makes sense. And the classic oldest example here has to be aspirin.
Absolutely. Aspirin works in a really interesting way. It irreversibly blocks an enzyme called cyclooxygenase, or COX. This prevents platelets from making something called thromboxane A2, or TXA2. TXA2 normally tells platelets to aggregate or clump together and also causes blood vessels to constrict.
And irreversibly means?
It means that effect lasts for the entire lifespan of that particular platelet, which is about 7 days. The platelet is basically knocked out of commission permanently.
Got it. Now, a quick but really critical safety point about aspirin.
Yes, it should never be given to children or teenagers who have flu-like symptoms.
Why is that?
Because of its strong association with Reyes syndrome, a rare but potentially fatal condition causing swelling in the brain and liver damage. Absolutely contraindicated in that situation.
Okay, crucial point. Beyond aspirin, what other antiplatelets are common?
Well, we have drugs like clopidogrel, brand name Plavix. These are ADP inhibitors. They work differently. They basically alter the surface of the platelet membrane so it can't receive the signal telling it to activate and stick to other platelets. They block a key receptor pathway.
So another way to stop platelets from clumping.
Exactly. And then, if we need the most potent, immediate antiplatelet effect possible, say, during a cardiac procedure like angioplasty, we use the GPI-BIA inhibitors, drugs like eptifibatide or tirofiban. These are given intravenously, usually only in the hospital, because they directly block the final receptor that platelets use to link together. It's like preventing the final handshake between platelets. Very powerful stuff for acute situations.
Intense. Okay, let's cover the last two groups, which really focus on manipulating that fibrin mesh we talked about earlier. We've got the clot busters and the clot stabilizers.
Right. First, the thrombolytics, sometimes called fibrinolytics. These are the only drugs we have that can actually dissolve a clot that is already formed.
The true clot busters.
Exactly. The main one is alteplase, which is a recombinant tissue plasminogen activator, or TPA. It basically mimics the body's own natural clot dissolver. It forces that conversion of plasminogen into plasmin, and then plasmin goes to work breaking down the fibrin in the thrombus.
And these are used in really critical situations, right?
Absolutely. Life or death scenarios, acute ischemic stroke where you have a very narrow time window after symptoms start, or a massive heart attack, acute MI. Time is brain, time is muscle. The faster you can give these, the better the potential outcome.
Is there an antidote if someone gets too much or starts bleeding heavily?
Unfortunately, no specific antidote exists for thrombolytics. Management of bleeding is really just symptomatic and supportive care. Thankfully, they have relatively short half-lives.
Okay. Now, on the complete opposite end of the spectrum,
Yeah,
the antifibrinolytics, these actually promote clotting.
they do. They're also called systemic hemostatics. They work by preventing the breakdown of fibrin.
How do they do that?
Drugs like aminocaproic acid and tranexamic acid basically interfere with plasminogen activation or plasmin activity. They stop the body's natural clot dissolving process. This keeps the clot stable and strong, so they're used in situations where you have excessive bleeding, like after certain surgeries or trauma.
Interesting. And there's one more, desmopressin.
Right. Desmopressin is a bit different. It's often used for certain bleeding disorders like hemophilia A or von Willebrand disease. It works by increasing the levels of factor VIII and von Willebrand factor in the blood, which helps platelets stick together better and aids clot formation.
Okay, fascinating range of actions. Given how dangerous all these drugs can be, the anticoagulants, the antiplatelets, the thrombolytics, let's wrap up by focusing on the absolutely crucial role of nursing. The nursing process.
Yes, this is paramount. These are high alert medications for a reason. First, assessment. It has to be thorough. You absolutely must check for any pre-existing conditions that increase bleeding risk. Things like active peptic ulcer disease, severe uncontrolled high blood pressure, any recent head trauma, or if the patient has an epidural catheter in place.
And baseline labs are non-negotiable, right?
Non-negotiable. You need a baseline complete blood count, CBC, especially hemoglobin and hematocrit, and the specific clotting studies, APTT before starting heparin therapy, PTINR before starting warfarin. Platelet count is critical too, especially with antiplatelets. If it drops significantly, say below 80,000, that needs immediate attention.
Okay, assessment covered. What about implementation, those practical administration tips?
Crucial safety points here. For subcutaneous injections, heparin or LMWH use the fatty tissue, like the upper outer arms, the thigh, or the abdomen, but always stay at least 2 inches away from the belly button. And 2 absolute do nots. Do not aspirate the syringe before injecting, and do not massage the site afterwards.
Why not?
Both actions significantly increase the risk of bruising and hematoma formation at the injection site. Just inject it smoothly and withdraw.
Got it. And what about that little air bubble you sometimes see in the pre-filled enoxaparin syringes? Should you push that out?
No, do not expel that air bubble. It's actually there on purpose.
Really? Why?
It acts as an airlock behind the medication. When you inject it, that bubble follows the liquid and helps ensure the entire dose is pushed out of the needle into the patient's tissue.
Huh. Okay, good tip. Never expel the bubble in enoxaparin.
Correct. And one more huge safety check, probably the most important one for preventing errors. Always, always stop and question an order if you see 2 different anticoagulants ordered to be given at the same time. Unless it's the very specific planned overlap when transitioning a patient from 5-E heparin to oral warfarin, that's the warfarin-heparin bridge therapy, we intentionally keep the heparin going for about 5 days while starting the warfarin because warfarin takes so long to reach its full effect. We need the immediate protection of heparin until the patient's INR is reliably therapeutic, usually above 2.0 from the warfarin alone. Then we stop the heparin.
Right. That overlap is planned and essential. Otherwise, 2 anticoagulants at once is usually a red flag.
A major red flag. Always clarify.
And finally, patient education. This seems like the last crucial safety net.
It absolutely is. Patients need to understand the seriousness of these drugs. You have to stress the importance of taking the medication exactly as prescribed, showing up for all follow-up lab appointments, especially with warfarin, maintaining that dietary consistency we talked about with warfarin, wearing a medical alert bracelet, or carrying an ID card.
And they need to know exactly what to watch for in terms of bleeding, right?
Yes. Teach them to report any unusual signs immediately. Things like excessive bruising for no reason, blood in the urine, hematuria, black, tarry stools, melena, nosebleeds that won't stop, severe headache. Any of those warrant an urgent call to their provider.
Okay, so we've really covered the landscape here. We looked at anticoagulants, which interfere with the cascade to prevent clots, antiplatelets, which stop platelets from sticking together,
Right.
thrombolytics, the actual clot busters that activate plasmin,
Yep.
and antifibrinolytics, which do the opposite and help stabilize clots. 4 distinct approaches.
And it really brings us back to that central theme we started with. The drug's mechanism dictates the need for monitoring. Think about it. The older drugs, like unfractionated heparin, hit multiple factors, creating variability, hence the need for constant APTT checks. But the newer agents, the DOACs targeting just factor ZA or just thrombin, were so much more predictable that they often eliminate the need for routine labs. That's really the paradigm shift in managing thromboembolic risks safely.
It's a huge change in practice. Now, this whole high-stakes field brings us to one final kind of provocative thought for you to consider. We spent all this time talking about how to safely start and manage these incredibly powerful drugs. But remember that black box warning on the DOACs, the factor Zeta inhibitors especially, that risk of potentially fatal rebound clotting event if they're stopped abruptly. It really reminds us that the ability to safely discontinue therapy is just as critical and potentially just as dangerous as safely starting it.
That's a really profound point. It underscores the delicate balance we're constantly managing in this area of medicine. Well, thank you for taking this deep dive into the complex world of coagulation modifiers with us today.
We really hope you feel better equipped and maybe a little less intimidated by these critical medications.
Yeah.
Until next time, keep digging deeper.